Dr. Cassidy.
Hey, gentlemen, loved all your testimony. At one point, I told my aide, be still my heart. I was so excited about what y'all were saying. And we have something online, which some of you have said things and perhaps directly referenced a white paper as to how to address and how to lower healthcare costs. Would love you to go on our website and give us a review because we're trying to implement some of this. I'm going to speak quickly, ask you to. I have limited time. Dr. Safer, you've mentioned that you do an intervention where you counsel people on diet to hopefully address the epidemic of obesity. Do you have longitudinal data? Does counseling on diet actually make a difference or not?
Yeah, no, we've made a large impact. I want to make one thing clear, which is that we open all these programs to more of the community that are in the risk.
Yes. But you've actually seen merely counseling, because it does seem multifactorial, but nonetheless, just by counseling, you've been able to get folks to lose weight?
Yes, and counseling includes other members of the group bonding with each other and working and being competitive and learning how to do it.
Got it. Let me move on. I'm sorry, not to be rude.
Sure.
Dr. Lansky, you mentioned the direct primary care model in your testimony, and for those not familiar with it, I call it the blue-collar concierge, in which you pay a monthly fee and the doc takes care of your primary care needs. Senator Cantwell and I have a bill out there for that. In your experience, just because I'm trying to socialize the idea, how could greater use of direct primary care reduce administrative costs to the system?
Right now, we have in the fee-for-service system, we have a lot of billing and insurance policies going on that are very confusing and generate an enormous amount of administrative work. Direct primary care, I think, produces essentially a version of a capitation for the primary care physician, which reduces the transactional data around the individual episodes and fee-for-service payment.
And I know that you know this, but just for everyone else to understand, if you look at the percent of a primary care doctor's billing that relates to administrative costs that relates to billing, it's much higher than for a surgeon.
Right.
A surgeon might be 2%, for a primary care doctor might be 25%, and so therefore that's where you can have the most impact of this.
Yes.
We'd like to expand that. Dr. James, you mentioned that a way to get at waste in the system is to use something like a DRG, or I compare it to an Uber driver. I got brought home from Dulles. I was reading. All of a sudden, I was on this circuitous route because the taxi driver had a vested interest in taking me to where it was the biggest traffic jam, right? I ended up in Reston. It was just incredible.
A beautiful community.
Beautiful community, but cost me an arm and a leg. The Uber driver, he's got a vested interest in getting me home as quickly as possible.
Yeah.
And so I couldn't help but think there's a comparison there.
Yeah, it's aligned financial incentives.
It's aligned financial incentives. Now, what can we do in Congress to better align that? When I speak to my physician colleagues, there's a great deal of complexity in coming up with the sort of information system, the data analysis, et cetera, that is needed to be comfortable taking on two-sided risk.
Yeah.
What can we do to aid that?
My personal answer would be to continue to invest in CMMI. The Center for Medicare and Medicaid Innovation, again, in both administrations, received some pretty good support, but that's their mission, is to work out those sorts of things. And at a policy level, I think that's probably one of the better investments you could make. The truth is it requires consolidation. It doesn't require ownership. So we have grand examples. Northern California, for example, we're an IPA model physician group. About 1,200 independent physicians came together and formed that group.
Now, IPAs, though, inherently, or at least traditionally, have kept the small practice model ethos as opposed to the more corporate of a Kaiser, for example.
That is correct. They evolve over time, though, and they start to develop the methods by which their members can benefit from this kind of coordinated care management. They start to develop information systems. They start to build better contracting.
So how do we facilitate that? CMMI would be to kind of reward those successful models and to promulgate?
Well, they test different models for payment. What we have currently are 7 or 8 different models for moving toward capitated payment, where you get full risk alignment, where you get full financial incentive alignment. I think we need more experimentation, more tests of different models on a broad scale.
So encourage that testing. One more thing, again, I may hang around for a second round. Dr. Lansky, I'm trying to think, what do we do about a state like Tennessee, a state like Iowa, Louisiana, where we have maybe one or two or no insurers competing in the individual market, the Obamacare exchanges. Now, when I look at Medigap, there's great competition, but in part because those insurance companies don't have to they don't have to go negotiate with a provider network. They can take Medicare rates and they're automatically in business. Now, I'm not saying we'd have to take Medicare rates, but you could take some multiple, 1.2, 1.5. What are your thoughts about using reference pricing, which you referenced in yours, reference pricing being Medicare, in which, or it could be Medicaid, but probably Medicare, in which somebody could go to a Tennessee, Iowa, or Louisiana and immediately compete with the dominant insurer? Of course, dominant insurer has the ability to negotiate a price. With this, the price is negotiated for them. That eliminates that administrative cost of that negotiation and allows someone to step in and compete with another insurer, which experience shows drives down cost. Any thoughts on that?
I think you're outside of my expertise on that, but I think conceptually it's an interesting direction to go.
Okay, I'm over time. I yield back. Thank you.